Welcome back, everybody. AJ, you look great in that blue, bro.
Thanks, bro.
You
You
got my
too,
heart
man.
racing.
Really?
Yeah.
I know,
feel like
bro.
I'm going to
It's
go
the
into
good
atrial
looks.
fibrillation.
It's the good looks. Atrial fibrillation.
You ever heard of atrial fibrillation?
Yes, I have actually. It's pretty common.
Yeah?
Yeah.
How common is it?
It's pretty common. I think
Okay.
it's probably one of the most common cardiac arrhythmias that I see personally.
In our office, at least.
Yeah,
Yes.
at least but you know what? It's been happening a lot more in the younger generation.
Especially with all the Red Bull and the Monsters and everything else they're
Absolutely.
drinking.
Stress, anxiety, it is just being triggered. And the problem is that we're not taking care of ourselves. We're not healthy enough to protect our chambers, our muscles of the heart. And all of a sudden, our heart just goes start dancing.
And goes into
So
it. Tell me what AFib is first.
Well, let's talk about the anatomy, right?
Yeah.
You have 4 chambers of the heart. You got the top part and the bottom part. Top
Yes.
part is the atria, bottom part of the ventricles, right?
Yep.
Typically, the right atrium, which is the sinus node, sends out signals to the heart to give it that electric beat, right? Now, the problem with atrial fibrillation is when the whole atrial muscle on the top part becomes out of coordination and just beats however it wants. What that tends to happen ultimately is with time, when the contractions of the atria start, being out of coordination, you can develop blood clots in that area. And if that blood clot goes through the right ventricle into the blood system, it could go into the brain and cause a stroke.
Most common. Actually, I just
Yeah.
had a patient yesterday.
Yeah.
I told him, hey, you have atrial fibrillation. It's dangerous. You can stroke out. They didn't listen to me. I ended up getting a stroke.
For sure.
So
Yeah, and then I think we also got to kind of mention paroxysmal atrial fibrillation versus just complete AFib, which is basically paroxysmal typically kind of goes in and out of AFib, and it does whatever it wants. And that's typically because the heart muscle's kind of still healthy, but the majority of patients need anticoagulation. And what that means is like blood thinners. You need to be on
to
a
make
blood
sure
thinner.
that you don't get a
Exactly,
stroke, right?
Exactly.
And so there's regular rhythm, there's irregular rhythm, and there's irregular rhythm,
rhythm.
which is atrial fibrillation.
Yes.
It's irregular.
Yep.
If you look at the EKG for the med students, there's no P wave.
Yep.
Sometimes you can confuse it for like SVT because
Yep.
sometimes SVT, but we're not gonna get too depth. If there's med students in there, you guys can explain it in the comments.
exactly. And that's what it comes down to, right? There's a lot of patients who are living with atrial fibrillation every single day, but their heart rate is controlled.
Yeah.
And of course, there's risk factors. There's certain calculations and equations that we tend to use in the medical field to calculate whether the patient needs to be on anticoagulation such as Eliquis, Xarelto, warfarin's the most common, Lovenox, etc., versus just being on aspirin.
Yeah.
Okay. So yeah, but that'll come. I mean, we don't have to go into too much detail, but let's talk about the little bit of the physiology about it. So yes, you need anticoagulation, and you need to be on this blood thinner, and typically you put the patient on a rate controlled medication.
Control it.
Yeah, to control the heart rate.
Especially when the heart rate is high. That's when it gets dangerous,
Yeah,
right?
it's around 120 beats per minute.
That's why they say
when you
rate
can keep it
controlled
under.
versus rate is not controlled. That
That's
makes
out
the
of
biggest
control.
difference in it.
For sure. But I'm telling you, it has become so freaking common in the office.
I'm
It's
seeing
like,
it very often.
I would say 10 to 20% of my patients have it. Literally, it's that much.
I don't know why I'm seeing it way more often in the office now. Like you said, it's getting more and more common. Our lifestyle, the new energy drinks, everything in your lifestyle is causing this thing.
Yeah, of course. And the scary part, MJ, is that a lot of people are walking with it and they have no idea that they have it because they're not going to really say anything until you present with symptoms.
Yeah.
Whether it's palpitations or just feeling tired or fatigued, etc. But
Like a little rattling in my chest is what they always say.
Exactly. I feel this rattle. I feel this kind of like palpitations. I feel like I'm anxious. Now, everything else that can cause an increased heart rate will, of course, exacerbate those symptoms, right?
100%.
Red Bull, energy drinks, Celsius. A lot of these energy drinks in general are kind of dangerous. It increases heart rate. Too much caffeine.
Especially if your baseline heart rate is already high.
Absolutely.
Right? So if your
absolutely.
baseline heart rate is high and you take it, you get above 100, then you're going to start getting the symptoms.
You're going to have symptoms.
And
for
also
sure.
you got to be careful with like replacing electrolytes. I always tell patients those electrolytes control a lot of parts of the heart, right?
Yep.
So you got to make sure that your potassium's good, magnesium's good, sodium's good, because once those start getting off rhythm, they
And
really
that
they put
affects
you
it.
in arrhythmia.
And that's why a lot of patients who present with AFib, for example, to the ER, we put them on IV fluids.
Yeah.
Right. So just in case they're dehydrated. Another one that I wanted to talk to you about was a lot of patients who are asthmatic or COPD patients who are on albuterol.
Yeah.
It increases heart rate. All of
Yeah.
a sudden, it's constantly putting them into AFib. So you got to be careful with that as well.
That's why we try to do the Zopanex so that you don't get as bad
As much,
of the effect.
exactly. So, that's pretty much AFib. I mean, it is pretty complex. You have to get, there's a certain calculation, of course, that you need to calculate. We use the CHADS-VASc score, for example, for patients to calculate whether they need to be on anticoagulation or not. And of course, a rate control medication.
We've been doing a lot more in the office. Like I feel like before we were always sending it to cardiology.
Yeah.
We're just getting so much better at it as primary cares to be able to treat it ourselves, figure out where the root cause is, and then go from there because there's always a root cause from it.
Of course. And if you are on a rate control medication, if you are on anticoagulation and you're still having symptoms or palpitations, the next one will typically be a cardioversion.
Yeah.
It's kind of like a reboot of the heart. And a lot of patients kind of go out of AFib afterwards, but it can come back.
And some of them don't need to be on anticoagulation, so they try to get their rhythm back by shocking the heart and getting it back into rhythm.
Yeah, exactly. But that by the time the patients have a cardioversion, typically their symptoms are just really bad and they've tried everything and it's not controlled. A third option would be an ablation also. So this is something that you probably have to talk to your cardiologist about. But these typically, like a second or third options, are come when you failed medical management.
Yeah. So if somebody comes into you and says, AJ, I'm having palpitations. My heart is beating abnormal. What's the first step?
For the EKG.
Okay.
That's what I would do.
So you get an EKG. It shows AFib.
Yep.
What's the next step?
It depends on their risk factors, their age, if they have a history of congestive heart failure, hypertension, diabetics. There's so many different risk factors.
Okay.
If I typically calculate the CHADS-VASc score, and if it's 2 or above, I typically put them on anticoagulation. If their CHADS-VASc score is low in the 1 range, I'll probably just start them on a high-dose aspirin or baby aspirin with a rate control medication.
I do fall into a tough situation sometimes where I had somebody the other day that was 92 years old.
Yeah.
He falls every week.
Yeah.
Right? And he went into atrial fibrillation, and we fell into a situation where it was like, okay, if we give the blood thinner and he falls, he can have a brain bleed and die.
Yeah.
If I don't give him the blood thinner, then he can stroke out and die. So what route do you go in that catch-22 where do you do in that situation?
That's a very good question, MJ. And it happens more often
Quite
than people
often,
think,
man.
right? There is no guidelines that actually recommends when to stop anticoagulation. Now, you can adjust the dose based on the patient's age, but that's a clinical decision that the primary care doctor
Such a tough.
It is tough.
I fall into that situation because we deal with a lot of older patients or geriatricians. So
of course.
It's tough because that final decision, because if you take them off of it and he strokes, you go wrong.
Yeah.
If you keep them on it and they fall and they bleed, then it's your fault. You put me on a blood thinner.
Yeah.
It's a tough situation. That's why to have a connection with your doctor and feel safe with him and be able to make a decision, you got to make that decision. And sometimes I leave it up to the patient. I tell them, these are the options. If you fall, I can't be with you every day, right? If you fall, you could bleed.
Yeah, but see, that's a decision you make also because you know your patient very well. If your patient had 7 falls in the last week, you want to get him off him.
100%.
If he had 1 fall throughout the year, then risk versus benefit, right?
Yeah.
Then I would kind of possibly put him on just a low dose aspirin if that's the case.
Yeah,
you know,
that's true.
just to kind of help a little bit, even though
something because the less chance of having that brain bleed.
Yeah, exactly. But again, then what do you control after that is the heart rate.
Put them on a rate I feel like the heart rate is the most important part.
Of course, because you'll have patients in AFib constantly. As long as their heart rates are under 120, they're really fine.
I have people in AFib with the heart rate 60, and
they're fine. You really don't need to put them on anti. They don't even feel it, and that's the case, right? But 120 is where that cutoff is. And I remember one of my buddies, Dr. Roxwell, he's a cardiologist. He told me to try to keep that heart rate at below 120 because the risk of stroke increases after 120 beats per minute. Yeah.
And if you know that you have AFib and you have a fast heart rate, don't drink coffee.
Yeah, exactly.
Improve your lifestyle.
Yeah,
don't drink energy drinks.
Yeah.
Avoid the triggers. You don't want to get to that point because once you get to that point, it gets really hard to treat.
Yeah.
We really don't want you to end up getting a stroke.
Of course.
And usually those end up causing the ischemic stroke, which we talked about, which is lack of blood supply to the brain because of the blockage.
Absolutely.
And so you want to be very careful with that.
Absolutely. So talk to your primary care doctor. Yep. If you have any symptoms that possibly you might have AFib, if it doesn't run in the family, whatever it is, talk to your doctor, get an EKG. Figure it out and just be careful. I think the most important aspect is patients need to educate themselves. You know, look it up online, read about atrial fibrillation, be the best patient you could be to make sure that you reduce your risk of stroke and to reduce your risk of complications.
And if you have questions, put it in the comment. And I just wanted to say, guys, I say this every episode, please subscribe to our channel. Yep. It's like 60% of our Instagram followers are not following our YouTube channel.
Yeah.
And it's kind of a little bit difficult to try to get you guys to go out there and just subscribe. If you guys rock with us, if you love Doc Talk, if you're a fan from day one and you're not following YouTube, then you're really not a day one fan.
Well, we're getting merch coming soon. So we'll be doing a giveaway hopefully soon. We'll
get us to 10K.
Yep.
We're kind of far from there, but if you get us there, we're going to give a nice giveaway. We're going to throw a party at the house. So
that'll be awesome.
Super excited, man. That was a great episode.
Well, yeah,
Thanks,
definitely, man. Enjoyed it. Thanks, brother.
All right.